All right, great. All right, so I have the venerable pre-lunch talk. I know it's been a big morning of really interesting talks, which makes me ask, I guess, am I a hematologist? I don't know. I never really thought about it, but some of my best friends are hematologists, and there have been some great talks so far. So what this talk is about, I think, highlights something that is helpful before I get into the meat of the talk here. I think it is helpful to look at the ABP guideline and see, well, what is the ABP asking, right? Because it's not always logically intuitive, and how does that align with your goals on this test? So, for example, the talk I gave yesterday was 3/4 of a page. The content I'm going over today is 5 pages. And if you look at how many questions are derived from those 5 pages, it's 6% of the total test. So if your goal is to crush this test, pay attention to every single slide and memorize every enzyme and every granule, if you want to pass, I would just sort of pay attention and enjoy the next hour. Okay? So again, we're just teaching to the test. So today's going to be on white blood cell disorders. And really, what that means, if you read the ABP guidelines, is we're going to talk about neutrophils for an hour. Okay? So I know most of us just kind of think that what's the ANC and move on from there, but there's a lot more to it, apparently. So I came across this quote. This article by Dale is actually a really good one, sort of on the history of granulocytes and why we think they are what they are. And so Galen in the sort of 100 or 200 AD came up with this concept of good and laudable pus. Because there was this observation that sort of when gladiators had these wounds that they seemed to heal much better if they had lots of pus. So that led to the practice that actually lasted through the Civil War of when someone had a wound to kind of get a rag filled with grease and kind of prep that wound to make sure that any wound that didn't have a ton of pus would develop some. So luckily we've abandoned that practice, but some interesting nuggets in granulocyte history. All right, but it does bring up the point. So what's the point of big picture, high-level stuff? Why do granulocytes do what they do? And the point is that, when we're born, we have to have immune responses, and we haven't really been exposed to anything, and we can still borrow some of our mother's antibodies. But in the meantime, we're coming through this sort of not very sterile introduction into the earth, and we have to have some responses to infection. And so, one of the problems is that bacteria, it takes bacteria 30 minutes or so to reproduce, but it takes us weeks to mount an adaptive immune response. So what's becoming increasingly clear is that we actually have this sort of semi-intelligent level of inflammatory responses where phagocytes, neutrophils, kind of more or less recognize shapes. So they know more or less what bacteria look like, what a wound looks like, what disrupted epithelium looks like, and they've created these receptors to recognize these sort of these patterns that don't look quite right. And even though it's not the exact antigen like we have in B and T cells, they go to that site, and that gives us our laudable pus with an inflammatory response. So how does this happen? So we have either infection or tissue damage, and that sort of disrupts the homeostasis of these surveillance mechanisms we have, whether it's complement system or endothelial integrity, or even sort of bacterial proteins or viral proteins. We get things like our toll-like receptors activated. We recognize lipids. That'll sort of elaborate some first responder chemokines that then gets the neutrophils kind of angry and agitated. And really what that happens is once this whole process, this cascade evolves, the neutrophils start leaking out of the vessels at sites where the problem is. So it's a way to really sort of dispatch sort of your first responders to sites where there's either some kind of tissue damage or some kind of early danger signal. And then, once they start sort of doing their thing, eventually the adaptive immune responses come to sort of finish the job. So I like to think of neutrophils as sort of the Marines of the immune system. They're sort of the first responders. They get recruited to the sites. These are the most abundant circulating phagocytes, and a lot of the talks we've had earlier about complement system, I'm glad Michael went over that so I don't have to. But really once you have your complement activated, once you have these chemokines and cytokines that are associated with cell damage, they don't really care what the specific problem is. They just know there's a problem they have to deal with. And I think complement C3 and IgG tagged organisms or tissues are some of their first response. And then so they'll gobble up whatever is tagged with these opsonins and then put them into their vacuoles and then release their poison into their sort of little gas chamber with the NADPH oxidase. So if you break it down, what I want to focus on, I'm going to go over some of the mechanics first, but then really what I want to focus on, because I think it's going to be on the boards more, is what diseases result when these processes are broken. So one of the things that ABP asks is to know basically this whole chart, which I think is absurd. But sorry, I'll go back one. As far as the growth factors associated with specific cells, whether it's megakaryocytes, with thrombopoietin, erythrocytes, with EPO, I would just really focus on what's different compared to everything else, because everybody needs SCF. IL-3 sort of is more or less generic for the myeloid lineage. So really focus on what's different. And so I think for neutrophils, what to focus on is GCSF and GM-CSF. And we kind of know that from our practice. And so the way granulate homeostasis works is we make all these precursors, and so I'm going to go into a bit about the sort of the details of how how do you manage the problem of we don't really want this pus everywhere all the time, but how are you able to sort of recruit these marines to a site when you need them, but then have them sort of waiting and not really causing problems when you don't need them. And so our bone marrow, as we all know, responds to GCSF and GM-CSF, and that leads to precursors, which then sort of have this homeostasis between a circulating and marginating pool, and then those end up going off to the tissue. And I think that this, just kind of understanding what the percentage of cells are at different stages sort of helps, because you can see here that the vast majority of cells are sitting in the bone marrow at some point kind of getting ready to be deployed. So really we have quite a lot of cells kind of getting ready for action that aren't really doing much. And if you see how long they last, so about 10 to 14 days, they can kind of hang around if they're not really activated, not really doing anything. But once they're mobilized, within 9 to 12 hours, they'll go go out of the bone marrow, they'll go into the peripheral blood, they'll kind of hang out on the endothelium waiting to be activated. And then once they are activated, they don't live very long. They're 24 hours once they hit the tissue. Okay, and so how does this happen? All right, so I'm going to keep coming back to this chart because basically every step in this process can go wrong, and with every step that goes wrong, we have a disease. Okay, so basically you have your neutrophils sort of minding their own business, floating around, and they sort of see that there's this danger signal. Right? You get some cytokines or chemokines, or some toll-like receptor activity that the receptor responds to that tells it it's got to kind of park down on the endothelium, so that the damaged epithelium starts expressing these selectins or these sort of molecules to recognize the neutrophil, also the cadherins. And so basically here, for example, you have the selectins recognizing this sort of the carbohydrate motifs on the Lewis X receptor on the neutrophil, which then kind of starts dragging the cells down. And they bind then the integrins and the integrin receptors, and then they start squeaking through the cells in this process called diapedesis. And then once they're in the extravascular space, they kind of use the chemokines to locate where the problem is, and then they find their bacteria or whatever it is that's covered with antibody and complement that tells it to gobble it up. And after they gobble it up, they put it into a phagocyte and kill it. All right, so we're going to go through each of those steps. And I think it's worth knowing some of these details. There's so much biology around neutrophils and sort of what are the different selectins and integrins and all this stuff. I think just having a high-level view is probably fine. At least I would start there and then fill in the details later and kind of fill out what's the most important. So I'm kind of listing here which ones are the most important. So the Lewis X or Lewis X plasma membrane receptor it's important to remember that this is a carbohydrate and it's recognized by carbohydrate recognizing motifs. L-selectins are on lymphocytes, we'll talk about in a second. The integrins are important. We're going to get into CD18 later on, but these are all sort of things that mediate. These are what's on the neutrophils. They start kind of rolling and they start kind of putting on the brakes as they roll over the endothelium. And then for chemotaxis, what are the things that sort of the neutrophil senses to kind of go towards danger? And this sort of makes sense. It's complement, it's some of these bacterial peptides, lipids that are expressed by bacteria and viruses, and then also some growth factor receptors. And then for the ingestion, they have to know what to eat. So if something's sort of coated in antibody, that tells the neutrophil this is something that probably shouldn't be here and it needs to be eaten up. Same thing with complement. And then once you've gobbled it up, you have to kill it. You don't want to just hold on to it. All right, and so when I have all the sort of those mechanisms on the right side, you can kind of read those independently, but each of the basically talks about all the different cellular processes associated with the different functions. Okay, and I think it's worth talking for a second about a couple of the different parts. So what are selectins? These are cell adhesion proteins that bind carbohydrates. And this becomes important because there's a few diseases where this carbohydrate recognition function doesn't work. And so in the case of neutrophils or PMNs, polyneutrophils, we'll say neutrophils, the L-selectins are also on monocytes and lymphocytes, and the function here is really for lymphocyte homing. And then the E-selectins are on endothelium, and then the P-selectins are on platelets. All right, the beta-2 integrins are important. These are transmembrane receptors that facilitate cell-cell and cell extracellular matrix interactions. And it's important to recognize this combination of CD18 plus CD11 whatever. So there's all these different CD11 alpha subunits that really define different kinds of sort of cell lineages as you go through. For example, the CD11Bs and Cs really kind of define monocytes and dendritic cells. But the point is that the common part of this is CD18, which we'll get to in a second, that becomes important. And each of these combinations really has sort of specific ligands that they recognize. All right, the other part of granulocytes that we want to talk about is differentiation. So how does a myeloblast become a mature neutrophil ready for action? And I think a lot of this we probably understand intuitively from AML, right? Different stages of sort of myoblast differentiation, we end up with different kinds of diseases. And so we kind of understand from the M0 to M7 in some ways a little bit how this works. But anyway, and we have this mitotic compartment sort of early on where you've got this myeloblast. It doesn't have much in the way of granules. That starts to sort of, the nucleus starts to shrink a bit, and you end up getting more granules. The myelocyte, you have more and more granules. And then we end up in this post-mitotic compartment where you've got your metas, your bands, and your mature segs, and we sort of recognize these as the sort of the cells in the blood that maybe reflect a bit of a left, this would be more of a left shift, this would be more mature cells. And it's important to recognize there's different kind of granules that define these different stages of development that go along with the different processes that these cells have to acquire. So eosinophilic, specific, tertiary, and secretory granules. So by the end, they have all of these. It's just in what order do they acquire them. And so I think because a neutrophil more or less has all the granules, by the end, it's not super important to recognize the different functions of the different granules, except for when there is a granule deficiency, and we'll talk about that in a second. So the eosinophilic granules, the point of these guys is to just sort of degrade proteins. They also carry defensins and myeloperoxidase, which we'll talk about later. There's a specific myeloperoxidase deficiency. The secondary or specific granules start to have a little bit more specialized function. So in addition to breaking down proteins, they also start binding some of the bacterial and plasma membrane parts. The tertiary start getting ready for ingestion. And then the secretory are sort of spare parts of plasma membrane proteins that they kind of carry around. I'm not sure how super important that is, but the information's there in case you want to review it. What is important, I think, is understanding the antimicrobial mechanism. So once the phagocytes have ingested their target, what do they do with them? Because the cells are their target that's ingestion isn't dead until it gets killed, and so this isn't a passive process, but it's mediated by oxidative metabolism. So you have to have sort of intact NADPH and myeloperoxidase, and if you're missing part of your oxidative metabolic machinery, you're going to end up with certain diseases that we'll talk about later. Okay, so now let's get to the diseases, because I think so. The first part was really just to set up sort of the parts and the rules, and now we're going to say, well, what happens if these parts are broken? So first off, what happens if you don't have enough neutrophils? Okay, so this, I guarantee, will be a question on your test. ASPHO will give you your money back if you don't have this question on your test. So a 13-year-old presents with lymphadenopathy and ANC, which is the most likely diagnosis. Okay, it's a viral illness. So most of the time when we see someone who has a low ANC, it's because they've taken some kind of hit. The virus has sort of stunted their bone marrow and their ANC is catching up, or the neutrophils have been kind of exhausted for a short period of time and are being replenished. Certainly you're going to have low ANC if you have ALL or AML and your bone marrow is crowded out, but that's not the most common cause. So neutropenia is sort of in the eyes of the beholder a little bit. It's basically just a lower than normal absolute neutrophil count. So that really varies a bit. I think in our minds we sort of think of certain numbers that we're comfortable with ANC, but it's important to recognize that it varies with age, and it seems like a sort of testable thing, even though it's something you can look up. But just remember that in newborns, the ANC is much higher than as you get older. And I think the thing that is very testable is that African Americans normally can have a lower ANC. So, an ANC of 900 might be normal. And then altitude. So I guess I don't know, I've never seen a question about like someone who showed up in Denver with an ANC of 1,000, but it's possible. Okay, and then there's sort of normal, mild, moderate, and severe. And what are the different risks? So I think we all kind of recognize this from our cancer patients, that if you have an ANC of sort of 1,000 or so, you're more or less fine. If you have between 500 and 1,000, or sort of mild neutropenia, again, it's pretty minimal risk. 250 to 500, we start saying, maybe you shouldn't hang out near the sick kids at school, and below 250, it becomes a concern. So how do we evaluate this? So I think like any patient that any physician takes care of, you want to figure out what they've been exposed to. What are their symptoms? How long have they had problems? Are there any associated infectious symptoms? Is this something that happens in the family? Has the uncle had sort of boils forever and they forgot to tell you about it? So some directed family history. And then physical exam. Is there something that suggests something syndromic? Specifically asking about mucous membranes, lymphadenopathy, et cetera. And then the lab sort of is an exhaustive workup to say, do you have cancer? Do you have autoimmune disease? Do you have some inherited syndrome that we haven't quite sorted out yet? Okay, so this slide is super busy, and I know Dan Zinn's one of my former fellows who's going to say, hey, how come you get to show a slide like that and you get mad at me when I put a slide like this together? And the reason is that I think it's important to know, Dan, everything on this slide. Okay? Because there's also something that's kind of quirky and weird, and so I would say that this is a high-yield slide to spend a little time remembering, and we can kind of go through some of the details, but these are all things that can lead to acquired infection. And they do spend some time in the ABP handout asking about each of these things. So I think just kind of getting the big picture, we all know that in general viruses and bacteria, et cetera, can cause neutropenia, but for drugs, it might be worth just sort of committing to memory a few of the specific drugs like sulfonamides and antipsychotics and anticonvulsants that are associated. So for immune, we'll talk about alloimmune and autoimmune. And then for associated, like what are the other things you're going to see with that? Because these are all going to be sort of patient scenarios. So you can kind of get together with your friends and come up with patient scenarios and see if you can guess which one of these problems there are. But I think this is, I don't need to go through each of these other than to say I think this is highly testable. Okay, so infection is the most common cause of neutropenia. Okay, I'll say it again, infection is the most common cause of neutropenia. Generally it's acute, and you just support the patient, make sure that your normal neutrophil count resolves at some stage. And again, viruses are pretty common. Also, some specific associations with rickettsia, malaria, leishmaniasis, histoplasmosis. Basically, anything that kind of creates a lot of cytokines that stunts the bone marrow. And then the mechanisms are multiple. It's not just the bone marrow suppression, but you're using a lot of the neutrophils. It doesn't, and it takes time for the marrow to come back. I think usually, though, the marrow suppression is kind of is the major reason why we have a delayed recovery. All right, so talking about drugs, again, I think it's worth spending a little bit of time remembering specific drugs that are associated, and it's a little bit hard. I think you can get a trick question because, so say someone shows up with a viral syndrome and gets an antibiotic and then has a low ANC. I think the correct answer for the test is that it's the viral syndrome and not the drug, but I think that's one of the questions that we have in the practice test. It's not really fair, but it's one that I remember showing up. And then, what are some toxic effects on the cells, and then also hypersensitivity, and sort of what are the different sort of onsets associated with each kind of drug. It might be worth spending a little time just kind of reviewing this chart. All right, so immune. So there's all kinds of immune things that can cause neutropenia, which is basically there's anything that can create antibodies against neutrophils. And when you have an infection, that's a good opportunity to create an antibody response. Or if you have autoimmune disease, it can look like an infection. Or if you're getting drugs, that can create an antibody response to neutrophils. So there's lots of things that can lead to neutropenia in the setting of sort of new immune challenges. All right, so has anyone here ever had a consult to the NICU about a baby who has low ANC? So, okay, I don't think I need to spend a lot of time on this slide. but basically 0.2% of all pregnancies. This can be a trick question with delayed cord separation. It's not always leukocyte adhesion deficiency. And then sort of just thinking about infections. If someone has an infection, is that what's causing the low ANC, or is that you have a low ANC and that's causing infection? So as often as we get this challenge, I think it's something that you can spend a little time thinking about, because you can come up with a tricky question on this. All right, chronic benign neutropenia of childhood is another common phenomenon. So in kids sort of just before a year who end up having a low ANC, if you check for antibodies, you're going to have an anti-neutrophil antibody, typically against the Fc gamma receptor 3 complex. Usually the kids are asymptomatic. Maybe it's picked up on a routine screen. If you look at the marrow, you're going to have increased myeloid series as the cells are trying to make up for the loss of peripheral neutrophils. And usually it goes away. It just has to be, once the neutrophils antibody is identified, you can just sort of support and observe. You can give GCSF in the setting of infection. Okay, autoimmune. So neutrophils are fair game with any systemic autoimmune disease. So basically any lupus, ITP, whatever, you can end up with low ANC if the neutrophil is recognized as a target. And the same sort of general advice applies that treat the primary disorder and then evaluate and treat infections, and you can give GCSF if you think that might be helpful. All right, so 2-year-old with recurrent infections, low IgG, warts is a key, and severe neutropenia. What does the bone marrow show? Let's think about that for a second. I'm not going to put anyone on the spot. So increased myeloid progenitor. So we're going to get to WHIM syndrome in a little bit. This is a WHIM syndrome case. And this leads us to really talking about some of the other disorders. So these are non-immune. These are sort of intrinsic disorders of neutrophil function that arise from problems with stem cells or stem cell precursors. So cyclic neutropenia is one of those things that kind of drives you crazy, because it kind of gets better and then it goes away, and it gets better and it goes away. The board seems to really ask a lot about this 21-day cycle plus or minus 4 days. I don't know. I think it's sort of like when they ask if a toddler is 9, 10, or 11 months, if they can do pincher grasp. I think there's a bit of variability, but the question is there. 21 days is the right answer. The reason why we have cyclic neutropenia, I don't think it's been completely worked out, but the neutrophil elastase gene has been implicated. And probably what happens is that the sort of a dysfunctional neutrophil elastase leads to a shorter half-life for the neutrophils. And so while you're usually kind of covered by this homeostasis of production and consumption, that wears off. And so you end up with these waves of neutrophil production. So if you have even more severely damaged production of neutrophil elastase or other sort of essential genes for neutrophil function and development, you end up with severe congenital neutropenia. So this really represents quite a broader spectrum of disorders, really more severe than cyclic neutropenia, and it doesn't get better. This can be associated with risk of myelodysplastic syndrome and AML, because the marrow is working hard to catch up. So because the disease is more severe, you're going to have more frequent and more severe infections. It's a bigger deal. Kostman syndrome is worth mentioning. It's a form of severe congenital neutropenia, but with neurologic abnormalities. So if you get someone who looks like they have severe congenital neutropenia, but they say they have these neurologic abnormalities, that's a very testable question, so I'd remember that. And the HAX1 gene seems to be involved in regulating apoptosis and metabolism in multiple different cell types. So it hits the brain and hits the neutrophils. I think it's not exactly clear, all the details. And then we end up with our sort of typical range of bone marrow failure syndromes that can really sort of show up first as neutropenia. So the things that we heard about yesterday, so you have misspelled Schwachman-Diamond syndrome, dyskeratosis congenita Fanconi, ataxia-telangiectasia, and probably add GATA2 deficiency to this as well. And then we have our granulin cytotoxic defects. And I talked about several of these yesterday in the context of HLH. So not only can they lead to dysfunctional T cells, they can also lead to dysfunctional phagocytic function. And so I think it's important to remember Shirek-Higashi and Griscelli syndrome. They have sort of the classic albinism. Griscelli syndrome specifically will have silver hair under the microscope. So I'd kind of remember those. Those are things that can be testable. I think if they give you both Shirek-Higashi and Griscelli, that's probably not really fair, because it's sort of hard to tell those apart if you're just talking about a baby with silver hair and some kind of cytotoxic defects. The difference would be that you have giant granules in Shirakashi where the Griscelli syndrome cells aren't going to look abnormal underneath the microscope. And then Hermansky-Pudlak, similar. But without the, they don't have the defect in melanin. Okay. All right, then there's disorders of metabolism. Okay, these are rapidly metabolizing cells. So anything where you have problems with glycolysis or with trying to keeping gas in the tank, that can manifest as a problem with neutrophils. And there's some specific diseases I've kind of mentioned here that I think are worth bringing up. And Pearson syndrome seems to get tested all the time because it's mitochondrial. Just remember mitochondrial inheritance for Pearson syndrome. That seems to show up. And then immune deficiencies. And I think these are also, we're spending some time on Sung-Young Pai is going to talk about these in more detail tomorrow during her talk. But, you know, if you have problems with your stem cell, your hematopoietic stem cells, you're going to have problems with your neutrophils as well as other associated functions. So, you know, if you have common variable immune deficiency, that can manifest as problems with neutrophils. IgA deficiency, you can have neutropenia. Certainly with SCID, you can have neutropenia. So WHIM syndrome, I think, is worth mentioning. That's why I gave it the highlight, because it's such a weird disease. So does anyone know what cathexis means? So I looked this up. It's like myelocathexis. Why do we call it that? So apparently it means like when you have an emotional attachment to something and you can't let go. So someone was being very clever when they came up with myelocathexis, because you're just so emotionally attached to your neutrophils, the bone marrow doesn't let them go. So that's how you have to remember it, is you need CXCR4 to leave the bone marrow. So if you don't have CXCR4, you make all these neutrophils, but they get stuck in the bone marrow and they can't leave. And there's some implications with CXCR4 and AML as well. But anyway, this is such a weird disease, it's worth remembering. And remember, warts and your marrow is packed with neutrophils. And then cartilage hair hyperplasia. So I put in green anything where I realized I made a typo when I fixed it here. So it's the RMRP gene. I think I had that backwards. But, you know, if you have a dwarf with fine sparse hair and neutropenia, I think that would be a little bit odd to test this because it's very esoteric, but there you go. Okay, and then idiopathic, which is my favorite category, which just means we haven't figured it out yet. So I'll skip that. Okay. All right, so now neutrophils just don't work, and why don't they work? Okay, so we have a 2-year-old with recurrent skin infections, delayed cord separation, abscesses, wound healing, which gene is mutated. So this is going to be CD18. So this is one that, again, guaranteed is, well, not guaranteed, but I'll give you an 80% chance of having the kid with delayed cord separation on your test and being asked about this. So leukocyte adhesion deficiency, so impaired or absent adhesion molecules involved in trafficking of neutrophils. So again, the delayed umbilical cord separation, recurrent bacterial infections, no pus in these patients. So if you have all these problems but no pus, impaired wound healing, leukocytosis, so you actually have this paradoxical really high number of cells. They're just not getting to where they need to go. And the severity of symptoms seems to be related to the degree of the genetic defect. So giving more GCSF or GM-CSF isn't helpful because you just add more stuff that can't get out to where it needs to go. And so if this is something where they just don't work as well, but they sort of work, antibiotics, wound care are fine, but if it's severe, you need to go to get a new immune system. All right, so let's talk for a second about the different leukocyte adhesion deficiencies. So again, CD18 leukocyte adhesion deficiency, remember that. That's one to highlight. So that's the primary cause of leukocyte adhesion deficiency, beta-2 integrin dysfunction, so you can't stick to the endothelium and get to the extravascular space. So leukocyte adhesion deficiency 2 is important. Now we're getting back to what I talked about before about carbohydrate receptors. So if you have a problem recognizing carbohydrates, you're not going to be able to bind to the sialyl Lewis X antigen, and so you're going to have less efficient binding to the endothelium and being able to get out. So if there are other carbohydrates that are stuck on cells that sort of co-segregate with this. So Bombay phenotype seems to show up. I think that was even in the board review outline. So you have no H antigen on your red cells. So if you have someone with like leukocyte adhesion deficiency and you do flow cytometry and there's no CD15, or if they say they have the Bombay phenotype, of which there have been 10 patients in the world reported, that's the correct answer. Okay? And it's not as severe as leukocyte adhesion deficiency. And these patients also have severe mental retardation and other problems because binding carbohydrates is important. So leukocyte adhesion deficiency 3 is kind of like leukocyte adhesion deficiency 1, except you have problems with signaling through CD18 and similar receptors. So it's a signaling defect. It's not an absence of the receptor. And I crossed out the CAL-DAG-GF1 because I guess when I was working on this, there were papers that suggested that was maybe implicated. They weren't sure which gene it was, and then a more recent paper suggests the FERMT3 is really what expresses kinlin and is responsible for this. So I don't think that will be on your test since it's just been characterized, but the general concept holds. All right, so here we go. So now we have this nice picture again. So what happens? So if you can't bind here, your cells stay in the endothelium. This is leukocyte adhesion deficiency 1. You don't have CD18. You can't bind carbohydrates. That means that your sialyl-Lewis carbohydrate doesn't work, doesn't bind. So that's leukocyte adhesion deficiency 2. And for leukocyte adhesion deficiency 3, you bind, but it doesn't activate the neutrophil. Okay, so let's talk for a second again about some more degranulation defects. So I know I mentioned some of these diseases earlier in the context of neutrophil development. Well, they also function in Shirakashi and some other fusion defects also impact function, not just development and differentiation. And I think Shirakashi has got so many weird things, it's very testable. This is something I'd spend a little time getting to know. So basically, it's a mutation in LYST is primary gene name. Sometimes it's still called Shirakashi syndrome 1 gene. And basically, you get a defect in membrane fusion and lysosome trafficking, so you end up with these gigantic inclusions in basically all of your phagocytes. There's also oculocutaneous albinism, recurrent skin infections, that's neurologic deficits associated with this. And it's also associated with HLH. So treatment is supportive care. When these patients get EBV, there used to be a lot of literature about sort of this accelerated phase of EBV, and it really is just macrophage activation syndrome or HLH, but it wasn't really recognized as such in the old days. But if you hear about accelerated phase in the context of EBV, it's really HLH in the patient with Shirakashi syndrome. All right, specific granule deficiency. So basically, if you don't have some of these transcription factors that are essential for creating granules, you don't make the granules. And if you don't have granules, that really impacts not just the development and differentiation of the neutrophils, but also their function. And so in the old days, the way you would do this would be to sort of do a electron microscopy, and you'd see that certain granule types are missing. I think that we probably don't do that quite as much anymore. The clinical features are going to be that you could have either decreased chemotaxis and or microbiocidal activity, mild neutropenia. So the bilobe neutrophils are important for alpha granule deficiency. And then recurrent skin infections. If you get weird infections, that's another highlight. So I think there's not a lot of things here that are super characteristic other than the lack of granules. I think if you had a question about this, you'd probably get some histology or some comment about there being no granules, because clinically it's hard to differentiate this from other neutrophil problems. All right, here's another one that you get a money-back guarantee if you don't get this on your exam. So, and it seems like it's so completely esoteric, so I'm going to help you remember this. So, child has recurrent granulomatous infections. The mother's DHR shows this. So, she is able to release a little bit of DHR, but not completely. Not in all of her cells, about half her cells do. So, this is going to be GP91 Fox. So, the reason to remember this is that it's the only one that's X-linked for CGD. So somehow associate 91 with your mother. If you can figure out some association in your brain about 91, then you'll get that question. Because otherwise, you get this on a test and your mind goes blank, right? Which one of these do I pick? So remember, something about your mom reminds you of what happened in 1991. Just try to kind of remember that. Okay? All right, so what happens with CGD? So in CGD, this is broken, right? You can't generate your gas chambers for your offending phagosomes. So it's really the problem, and it sort of just depends which part of the electron transport chain is broken. All right, so for chronic granulomatous disease, this is, again, the most common neutrophil defect other than infections. So you just remember, it's important, I think, to spend some time remembering this because it is the most common. So recurrent skin infections, long lymph nodes in infancy, so liver abscesses, osteomyelitis can develop. If you start having some really weird infections like aspergillus, burkholderia, serratia, nocardia, that's not normal. There's something weird going on that you have to look at. And then you end up with these sort of chronic inflammatory granulomas because you sequester, but you can't get rid of the immune stimulus. And then there's different kinds of tests. In the old days, we did the nitroblue tetrazolium, which sort of would figure out if you had enough acid to turn yellow to purple from activated neutrophils. Now we typically use this flow-based dihydrorhodamine, 1,2,3. It's a flow-based assay that I just showed you, and I wouldn't be surprised if you see that assay on your test. So, Google a few examples of them or ask your lab to show you, because I think it's important to be able to interpret those. And then family history. Remember, your mom's uncle always had these boils. That's the answer. And then you can also do targeted sequencing or whole exome sequencing, which seems to be becoming more routine. So patients with CGD who have clinically significant CGD will get sulfa and itraconazole prophylaxis. Sometimes prophylactic interferon gamma can help with non-oxidative phagocytosis, although it's not very fun to be on interferon gamma, as some patients will tell you. And then transplant if it's severe enough. Okay, myeloperoxidase deficiency. So remember we had the NADPH, but then myeloperoxidase also plays a role. Not quite as significant a role as NADPH. So these patients are generally okay, but if you get on your test C. albicans or aspergillus and diabetes, it's myeloperoxidase deficiency. So for whatever reason, patients with diabetes and myeloperoxidase deficiency do really badly. So you need antifungal prophylaxis for your children with diabetes who have MPO deficiency. Pretty esoteric, but it's something that's testable. Okay, then there's some other sort of miscellaneous defects, and these are just things that sort of have been discovered that lead to various aspects of neutrophil dysfunction. So it's G6PD. Not only can you bust your red blood cells, you can also impact, after your fava bean dinner, you can end up having neutropenia. And then RAC2, this RAC2 GTPase, I would just remember it as RAC. RAC is required for chemotaxis. There's it's a new immune deficiency that's been described recently. Then I think IRAC4 is worth remembering because it's kind of a unique mechanism. So with IRAC4, your toll-like receptor signaling is impaired, which leads to severe recurrent infections. And remember, your toll-like receptors are part of what trigger your neutrophil marines, that there's a problem. So if you can't signal through, you don't respond to LPS, you don't respond to toll-like receptors, you have blunted responses to infections. So remember IRAC4 deficiency. Okay, on to other myeloid. How are we doing for time? All right, we'll get there. Other myeloid dysfunction. So the good news is I talked mostly about other myeloid dysfunction yesterday. So we're just going to talk a little bit about what can go wrong with monocytes, macrophages, and dendritic cells. So it turns out that macrophages and monocyte-derived macrophages are actually really important for certain kinds of infections, specifically atypical mycobacteria. And that response seems to be linked to interferon gamma function. So when you have an interferon gamma receptor deficient patient, the classic scenario is going to be that they have atypical mycobacteria infection. And if you get that question, you want to look at interferon gamma receptor gene as well as the IL-12 receptors. The treatment is to give more interferon gamma if they have partial function of their receptors, or go to BMT. This is a relatively new class of disease, so I'm not sure it's made it to boards, but I'm sure it will make it eventually. And then hyper-IgE syndrome, or Job's syndrome. So these are various mutations in JAK-STAT signaling. So JAK-STAT signaling is really important for a variety of immune functions. Specifically, it seems to be important for neutrophil chemotaxis, T-cell responses, IgE regulation. And so these patients will end up with super high IgE, really high eosinophil count, and their immune system sort of turned on, but it's not functional. So you end up with a sort of chronic state of smoldering infection. And I mean, it's a horrible name to give to a disease because, I mean, so remember Job? I remember Job had a bad time, but I had to Google this. So Satan basically covered Job in sore boils after taking away all of his money and everything else. And that's not a nice disease to be able to describe to a patient. I think hyper-IgE syndrome is better. So anyway, sinopulmonary infections. But the thing that you'll get on this is they have very characteristic broad nose, right? So if you've got a broad nose and if you retain your primary teeth, that's very characteristic of this syndrome. So if you've never seen a Job syndrome patient in real life, Google one because it's a very characteristic appearance and it's very testable. Again, I'm sounding, I guess, a little not compassionate, but everything today is about the test. We'll deal with patients in another class. Okay. So new pop quiz. So you've got this 1-year-old who's losing milestones, develops hepatosplenomegaly and cytopenia. This is the bone marrow aspirate. You see these crumpled bag cells, these gigantic crumpled bag sort of histiocytes. So this is Gaucher's disease. So you can get really severe hematologic problems from Gaucher's disease. And the problem is that you're not metabolizing your glucose cerebroside, so you end up with you end up with glucose cerebroside dysfunction, so you end up accumulating the carbohydrates, and you end up with these senescent blood cells and monocytes and macrophages that get packed with this sort of cellular garbage that you can't get rid of. And so there's type 1, type 2, type 3. Type 1 does not have CNS involvement, so that sort of can be a trick question. You don't have to have CNS involvement to have Gaucher's disease. Type 2 is very severe CNS involvement, very severe hematologic involvement, and type 3 is kind of intermediate. All right, but remember crumpled bag cells. And so what's the solution? So some people are fine, depending on what their specific phenotype is and what the specific mutation is, but enzyme replacement can sort of preserve neurologic function and can restore heme function if you have really severe symptoms, BMT, and I think this is something that's being worked on for gene therapy. All right, so let's get into too many myeloid cells. These are sort of generic things, but something to think about. So if you have really high leukocyte count, that can be due to a lot of reasons. How many of us have gotten a consult because of an ANC is like 30,000, right? And you say, well, the patient has a really bad infection. So infection, stress, smoking, pregnancy, exercise, glucocorticoids, right? Anything that gets all those neutrophils out into the periphery can give you high ANC, as can myeloproliferative disorder. So you do want to make sure that these are just sort of activated, angry, responsive, functional neutrophils and not pathologic, neoplastic neutrophils. Monocytic leukocytosis, so high absolute monocyte count. So I think the most famous version of this is going to be your primary EBV infection. So if you have some sort of scenario of a teenager, coming home with big lymph nodes and huge white cell count and it's elevated monos, that's what that is. So EOs, we don't spend a lot of time thinking about EOs, but just remember that the main thing with eosinophils is parasites, but it can also be a harbinger of leukemia. So I'm not sure how one would test that, but just keep in mind that, I think parasites is probably the thing that will be tested, parasites and allergic reactions. And then basos are even sort of a little more esoteric, but those are going to be elevated usually in the setting of as eosinophils, but I think there's some specific consideration given to hypersensitivity reactions, ulcerative colitis, rheumatoid arthritis. All right, dendritic cell function. So myeloid cells or monocytes can differentiate into macrophages, which we've kind of talked about as being sort of professional phagocytes, but they can also turn into dendritic cells, and dendritic cells are professional antigen-presenting cells, and the job of dendritic cells is to coach T cells about what they're supposed to pay attention to or not pay attention to. And so here's a little cartoon I have for Langerhans cells, my favorite dendritic cell, but you can extrapolate this to basically any dendritic cell. So basically, these cells get seeded when we're in fetal life. So they actually come from fetal liver, and these precursors sit in our epidermis. 1% of our skin is made up of these epidermal Langerhans cells, and they just sit there and for the most part do nothing. But what happens is when an antigen comes along, they get a stimulus, either trauma or an infection. They kind of pull up their anchor, they pull up their E-cadherin, and they get stimulated by all these cytokines, and they migrate to a lymph node. So they just kind of sit everywhere, and their job is to kind of, when the alarm bell gets sounded, they don't act like neutrophils and go straight to the damage, but they figure out they kind of bring their damage signal to a lymph node, and in the draining lymph node, they talk to T cells, and in the context of MHC, they instruct the T cells which antigens to either respond to or to not respond to if it's inhibitory. And I've been told that a question on my test is wrong, that number 17 should be D and not B. It is MHC class 2 that talks to CD4, okay? So just can make a note that when you get to that question, it's not B27. But anyway, the point is that the antigens are in the context of MHC, and they present that to either the CD4 or the CD8, depending which MHC it is, okay? And then so once the dendritic cells or antigen-presenting cells show the T cell and say, hey, if they have a match, if this T cell's antigen or T cell receptor matches the antigen being presented by this dendritic cell, then they bring more and more T cells to the site, and this T cell proliferates, and they start elaborating cytokines. And the point is that these T cells will start killing anything with that antigen until it's cleared. And then once all these cells carrying that antigen are cleared, so the dendritic cells and macrophages have sort of gobbled up all these, the antigen that the T cell is now recognizing, and so it's saying anything that's marked with this antigen, kill it. And so once the T cells have done their job, the whole thing dissipates and homeostasis is restored. Okay, and that's sort of what goes wrong and all the stuff we talked about yesterday with myeloproliferative and histiocytic disorders. So we will not talk about that again today. All right, so I just have a few, just to see, I'm wrapping up here, actually a few minutes early, but there's a few things that are just too good to test that I think could stand a good chance of showing up, so it's worth spending a little bit of time. So what is this? Giant platelet, some kind of weird thing in here, some kind of inclusion body. So Pelger-Hewitt, May-Hagelin, Shirakashi, Gaucher. So this is a May-Hagelin anomaly. So big platelet inclusion. It doesn't really mean anything. It's just sort of some anomaly that happens, but it has a name and it's weird, so it's testable. Okay. So Pelger-Hewitt anomaly is another thing that just kind of shows up. We'll see this every once in a while in our smears, and I always call the pathologist and say, "What should I do with this?" They say, "I don't know. It's just we saw it, so we thought we'd tell you." So basically, you have a hyposegmented in Pelger-Hewitt, a hyposegmented nuclei, immature neutrophils. So they don't get lots and lots and lots of folds in their nuclei. It's just either a bilobe, dumbbell, or peanut shape. It can be acquired in leukemia or MDS. So I guess that's one thing, one context to understand is if you see that, make sure the patient doesn't have leukemia or MDS, which can really make your cells look dysplastic or unusual to begin with. And the May-Hagelin anomaly, the reason why it's important to recognize this, it can be nothing, but can also be related to this sort of MYH9-related diseases. So you get the spectrum of mutations that can cause bleeding, deafness, nephritis, cataracts. So sometimes those platelets maybe don't work. So I think a good homework slide is some things that I came across. I wish I could just cut and paste things. You know, like Michael Jang mentioned, we had to do all our own cartoons, which leads to the, some of the quality of the cartoons that you have. But it's worth kind of Googling and spending some time looking at neutrophil maturation and Google images, Shirakashi, secretory granule deficiencies, Pelger-Hewitt, May-Hagelin, Gaucher cells. Kind of make yourself little sort of tester slides on those, because I think those are things that could show up in the image part of your exam. All right, I got a bonus slide. So I'm not really doing, so I'm doing leukocytes, but I'm basically leaving lymphocytes to Sun Young Pai tomorrow. I think that's mostly in the context of immune deficiencies. We usually think about lymphocytes or leukemia. But ALPS is another thing that's just so classic, it'll get tested. The board review only has 2 lines on ALPS, but I seem to remember a lot of questions. And I always hear people saying, oh man, there are so many questions on ALPS. So, but just remember autoimmune lymphoproliferative syndrome, it's a weird disease because it looks like leukemia, but the cells just don't die. And again, I'm totally switching gears here. We're talking about lymphocytes. We're not talking about neutrophils or myeloid cells anymore. But these are B and T cells that accumulate, double negative T cells, right? You'll get a flow chart and you'll see this increased number of double negative T cells. Double negative means basically that as the cells mature in the thymus, you start off as having the alpha beta, I'm sorry, the TC, on the TCR receptor, you'll have the different gamma chains and alpha beta chains and gamma delta chains, and then they end up basically being absent on these cells. So it's sort of a defect in thymocyte maturation. And this occurs because of a problem with fast ligand caspase 10 mutations. It's associated with autoimmune cytopenias. It's in the context of elevated vitamin B12 for some reason. Kennedy Rao discovered that. I don't know why, but you have elevated vitamin B12. But remember, double negative T cells is going to be ALPS. So, and the way to treat this is to either do nothing, just give MMF, rituximab, IVIG, or mTOR inhibitors. And I think sirolimus is becoming standard of care, but that may not have made it yet. And don't take the spleen out because that subjects if you take the spleen out, that'll subject the patient to risk of infections. All right, so I have a clarification of an alternative fact from yesterday's talk as well. So when I was first making my slides, I realized when I talked about genotype-phenotype correlations in your packet, right, it was the difference between, I was talking about the difference between PTPN11 and KRAS compared to Sybil. But the way it read, I saw that it was confusing. So in the actual talk, I clarified basically any of these sort of inherited mutations associated with JMML and a Noonan syndrome or even the Sybil mutation. These patients present younger, they tend to do better, they can spontaneously resolve compared to the monoclonal somatic mutations that arise. So just to clarify, if you get a question about JMML with Noonan syndrome, they do better than somatic. I think it would be pretty absurd to ask a question about the difference between Sybil and Noonan and PTPN11, but it was sort of mentioned in the board review materials. So I would just say cross out that slide because it adds more confusion than it helps. So I apologize about that. I had a few people ask me about that yesterday. All right, that's it. And we have 5 minutes to spare. Good luck.